Welcome back everyone. We'll start with our post-lunch sessions. May I please invite on the dais our chairman for this session, Dr. Manpreet Bhalla, HOD and consultant in Department of Microbiology at NITRD. Dr. Rajkumar Yadav sir, HOD in Department of CTVS, SMS Medical College. We have already announced, sir. Dr. Vikram Vohra, chest specialist at NITRD, sir. Yeah. Okay, sir.
Good afternoon, ladies and gentlemen. Now we start the post-lunch session, and this will be a pre-operative aspect of thoracic surgery. So, first speaker is Dr. Anil Kapoor. He will be speaking. He is the Director Thoracic Surgery, JP Hospital, Delhi NCR. And he will be speaking on pre-operative evaluation for lung surgery.
Thank you very much, Chairman, sir. At the outset, I must thank Dr. Devan, Dr. Pallavi, and the whole organizing team of this CME. Greetings from the historical city of Meerut, from where the War of Independence started in 1857. The topic given to me is pre-operative assessment of thoracic surgery patient, although it is very, very important and very lengthy topic. I would quote a Chinese quote, and I'll read it in reverse form. Inferior doctors are those who treat the full-blown disease. The mediocre doctors are those who treat the disease before any untoward complications. But the superior doctors are those who prevent the disease. So probably it goes absolutely true for preoperative evaluation for thoracic surgery patients. We have to assess the patient for the things which can reduce the mortality, morbidity, and complications of surgical interventions. So the risk models, according to the British BTS guidelines, for every thoracic surgery patient undergoing surgery, they have to be evaluated with some risk modules. There are different risk modules, but most of the risk modules are for cancer surgery. In Indian scenario, the risk factors and the modules for thoracic surgery, they are not very well documented and reported. But what we do initial assessment and the final assessment. Final assessment is one which is done exclusively by the anesthetist just before surgery. But for the initial assessment, the thoracic surgeon, the pulmonologist, even the anesthetist and cardiologist, they should all be involved in this. As Dr. Devan yesterday asked, what would be the one-line assessment? So probably this picture depicts it. The pre-anesthetic checkup is on 4th floor, no lift. You have to go by stairs. If you reach there, definitely you are fit for surgery. So that's, but most of the time it is very confusing. Initial assessment starts with history of cardiopulmonary disease, comorbid conditions like diabetes, renal failure or renal impairment, liver or renal involvement, current medication, allergies, tobacco and alcohol use, and weight loss. All these things are to be addressed in initial assessment. Physical assessment, the examination of physical assessment includes the assessment of overall appearance, the weight loss, especially cachexia and generalized wasting, cervical, supraclavicular or other lymphadenopathy, cardiovascular examination, murmurs, arrhythmias, peripheral edema, respiratory rate, use of S3 respiratory muscles, or presence of wheezing. They should all be noted and accordingly addressed. Routine investigations which are to be done, complete pre-op blood test, especially the hemoglobin, the creatinine, and the serum albumin proteins, BTCT, etc. ABG, X-ray chest, ultrasound abdomen to rule out any other disease or involvement of other organs. CT chest, including the upper abdomen, including the liver and the adrenals especially. Bronchoscopy, ECG, echo, pulmonary function test, and DLCO. These are the routine tests which should be done pre-operatively. There is difference between malignancy chest surgery and non-malignant, non-cardiac surgery. Malignancy itself is never a truly elective surgery, because in case if you delay cancer surgery because of pending investigations or some procedures, then chances of spread of malignancy are always there, so you should be very careful about it. The three-legged stool test for respiratory assessment, as we all know, is the lung mechanical function, the pulmonary parenchymal functions, and cardiopulmonary interaction. So respiratory mechanics is diagnosed by spirometry, and parenchymal function can be assessed by DLCO, PaO2 and PaCO2 on ABG. The cardiorespiratory interaction, that can be assessed by CPAT, stair climbing test, and the SpO2 fall of more than 4% in exercise test, that is shuttle walk test or stair climbing or 6-minute walk. Level 1 investigation or assessment are important because major perioperative risk of atelectasis, pneumonia, and respiratory failure are in the range of 15 to 20%, and cardiac complications like arrhythmias and ischemia are around 10 to 15%. So we have to just prevent them from happening. In spirometry, you note down everything, and that is to be expressed in corrected way in the percentage predicted. Predicted post-operative values for FEV1 and DLCO should be measured, and they should be calculated. And with formulas which are available on apps and net, you can easily calculate the percent predictive values for FEV1 and the DLCO. That is very important. And this is how the segments are distributed. But whatever predicted post-operative value you calculate on the basis of investigation, that may not be the actual measured values of FEV1 and DLCO in post-operative phase, because of the injury which is caused during the surgery to the chest wall and the lung. So the actual measured FEV1 and DLCO is comparatively less as compared to predicted ones. But these things, they improve within 6 months or so. Patients with predicted values less than 40% FEV1, they should be subjected to a complete pulmonary function test in pulmonary lab for lung volumes and airway resistance. Formula for estimating the predicted post-op value for FEV1 and DLCO in cases of lobectomy should be calculated by the anatomic method. But for the pneumonectomy, it should be calculated on the basis of the perfusion method. And there are different formulas which are available. These were level 1 tests. The level 2 tests are 6-minute walk test, the staircase climbing test, and the shuttle walk test. For level 2 6-minute walk test, if a person can walk for 400 to 800 meters without any obvious or disproportionate discomfort, then probably he is fit for surgery. Stair climbing should be approximately 20 to 22 meters, and shuttle walk test where the 2 points are around 10 meters apart, and gradually the work is increased, the speed is increased, and in case if the patient can complete 400 meters, he is fit to undergo surgery. Another important thing before I go to level 3 is the cardiac risk factors. These are to be considered before you go to level 3 assessment module. The smoking, hypertension, hyperlipidemia, advanced age, diabetes mellitus, and history of cardiac disease, they should all be taken into consideration. And the BTS guidelines are that all patients who are to be subjected for lung resection, they should have a preoperative ECG. All patients with an audible cardiac murmur, they should have an echo. All patients who have had a myocardial infarction, they should be postponed at least for 6 weeks. And any patient who has had an MI within 6 months before the proposed surgery, he should have a cardiac evaluation by a cardiologist. So, now we go to level 3. If post-operative positive high risk for cardiac evaluation is there, or there is predicted FEV1 and DLCO less than 30%, or the stairs climbing test is less than 22 meters, or shuttle walk test is less than 400 meters, then the patient should be subjected for cardiopulmonary exercise testing, CPAT, which tells you about cardiovascular, respiratory, skeletal muscle, and neurophysiological systems. We can calculate predicted VO2 max on the basis of height, age, gender. This is the predicted value, how much it should be. But you calculate actual values on CPAT and you compare the two things. So if the VO2 max is less than 35% of the predicted one, or it is less than 10 ml per kg per minute, then it is a very high risk patient. You should consider other non-surgical measures. VO2 max between 35 to 75% or between 10 and 12 ml per kg per minute. Then you should take into, this is moderate to high risk, then you should consider whether, okay, I have to go hurriedly. VO2 max more than 75% or 20 ml is low risk. These are the, so now after having evaluated about these, so if the patient is high cardiac patient, directly you go to level 3 investigation. If it is not, there are no cardiac high risk factors, then you level 1 test, and if it is mild, go directly to surgery. If it is moderate, then go to level 2 test, and if it is high, then again you go to CPAT. So gold standard is CPAT in case if other things are not good. Stress echocardiography is also done, but probably in comparison to the CPAT appears to be gold standard. There are some factors which are associated with an increased post-operative renal impairment like increased preoperative creatinine, diuretic therapy, pneumonectomy patients, post-operative infections, blood loss during surgery, and pre-operative cisplatin chemotherapy, which has got renal impairment. In COPD patients, all the patients should be subjected to ABG investigation, because there are some patients who are carbon dioxide retainers, and these patients, when you give high FiO2 during surgery, they get toxicity. And another important thing is that in case if you are planning for a epidural catheter to be placed, then the prophylactic anticoagulation is also very important to consider, because it should be either 2 to 4 hours after placing the catheter, or it should be about an hour before. So I'll just go hurriedly. Carcinoid, when you are operating for carcinoid, sometimes they secrete vasoactive mediators, and drugs like bleomycin, they exudate oxygen-induced pulmonary toxicity. Mass side effects, you should always consider. Metabolic effects in cases of tumors like hypercalcemia, hyponatremia, Cushing syndrome, metastasis, they all should be considered. Some drugs like bleomycin, mitomycin C, doxorubicin, cisplatin, they should also be considered in preoperative phase. Another entity is thoracoscope for evaluating the risk factors for thoracic patients. But in Indian scenario, there are so many literature, so many publications, that it is not very relevant in Indian scenario, mostly because it doesn't take into consideration of pulmonary arterial hypertension. Because in tubercular patients, usually PAH is there because of damage caused to vasculature, endarteritis, and parenchymal architectural changes, and even in redo surgery. So now comes the final preoperative assessment, which is done by anesthetists, and they consider two things mainly: the difficult endotracheal intubation, which can be diagnosed with the history of previous radiotherapy or previous pulmonary or airway surgery, plain X-ray chest and CT scan and bronchoscopy, they are very useful, and factors which can desaturate patient during the anesthesia. So high percentage of ventilation on VQ scan or perfusion on the operative lung, or there is poor PaO2 on two lung ventilation, especially in case if you measure it in a lateral position, right-sided thoracotomy, restrictive lung disease, supine position during surgery. They all are the factors which can desaturate the patient during anesthesia. Thank you so much.
Thank you, Dr. Kapoor, for elaborating everything about the lung function test. Now it's open for discussion. Any question from?
You said that benign, just because we do more benign disease, they have more pulmonary artery hypertension, that may not be correct. I don't think if we do echo, PAH is not present in majority of our cases. What is important is that there is ventilation perfusion mismatch. So we are able to probably get away with more resection with lesser effect on the pulmonary function. The two things I think need to be differentiated. Thank you.
But there are so many presentations.
PH, did you do how many echoes in which pulmonary artery pressure normal is between up to 25 mg? So up to 25 will be acceptable. In majority of the cases, some of the cases above 40 we do echo. We don't have a PH which is high. And Dr. Yadav must be doing in majority of cases because you are in a cardiothoracic unit. So PH, does it take place in infective conditions? Pulmonary artery hypertension.
Very late.
Because of the restriction of the lung and arthritis and things like that. Because of that, the pH can increase. So you have to just measure pH. In case if it is higher, then preoperatively, definitely you have to, think about it. If it is normal, then it's okay.
pH is a still cardiac condition like atrium, mitral stenosis and those things.
No, core pulmonary is a situation where the pulmonary hypertension because of lung conditions.
There are
COPD,
that may be there, yeah.
In cases of a very long-standing lung fibrosis, you do get pH as a result of the loss of lung vasculature, and it is mainly a secondary pH. But I am not very sure how much it would interfere with the surgery and pre-anesthetic.
So actually, all stage 2 and 3 stage patients of COPD, they should be subjected for this ABG, because those are the patients in where the pH is supposed to be increased, stage 2 and stage 3 of COPD, because of long-standing COPD.
Dr. Kapoor, I had just one question in this particular thing. When you talk about level 1, 2 and 3 of pre-assessment, do you mean that a person goes, he is evaluated as level 1, if he fails level 1 and then he goes to level 2, and then if he fails level 2 he goes to level 3, or you do all of them 1, 2 and 3?
No, sir. See, I showed that chart. In case if the patient is of high risk cardiac patient, then definitely he'll go to level 3, that is CPET.
Oh, no.
If there
My
are no-
question is different. My question is, if a person fails on level 1, do you go to level 2, or you just simply say, okay, the patient is out of surgery?
So in level 2, in case if the patient has got good FEV1 and DLCO, then we can proceed to surgery.
Okay.
Provided other conditions are not there, like patient is not.
Clearly mentioned in the surgical clinics of North America that when the last one came, that if one clears the level 1, then there is no need to do level 2. And it's only on the intermediate borderline cases which you go to want to do it. Normally, but you see, as a matter of fact, still we take an overall picture. Sometimes, Dr. Ashwini is not here, but Dr. Prakash is here. Sometimes even if they don't meet these parameters and we feel there is an emergency, the hemoptysis, etc., patient has to be taken up, we do take up and we get away with those results.
Dr. Kapoor or anybody of the surgeons or some pulmonologist, what about the differential lung function test? Do we do them sometimes, or it's just for a
We don't do that on routine basis, but and again it's not, differential lung function is not available in many units.
Because that is the real one, after removing particular part of one lung, half lung or full lung, that remaining lung matters.
So every patient. Sometimes you cannot generalize the thing. Every patient has to be evaluated, custom made.
Yes.
So, by differential lung function, if you mean VQ scan or lung perfusion scan, we usually do that for more so for pneumonectomies in which the pulmonary function test is borderline. So, if it is the predicted post-operative FEV1 is borderline or borderline low, or if the TLCO is low, then that is where we do the perfusion scan to know that if the affected lung is, how much it is contributing to the total lung function. If the contribution is really low, then your predicted post-operative FEV1 can be calculated on depending on that, and you can safely take out that lung.
Thank you, Dr. Kapoor.
Thank you, sir. Thank you.
Abdullah? Yes, this way.
We move on to the next speaker, Dr. Amol Bhanusali. He is currently the medical director of Dr. Bhanusali Hospital and Center for Lung Surgery in Thane, and he is also a consultant thoracic surgeon at Hinduja Hospital, Mumbai. His topic is operating room infection control practices for thoracic surgery.
Very good afternoon, respected chairperson, senior colleagues and friends. My talk today is based on the guidelines given by the Infection Control Prevention guidelines by the Ministry of Health and Family Welfare 2020, and also the WHO guidelines and CDC guidelines. So, healthcare associated infections are acquired by patients and represent the most frequent adverse effect affecting patient safety worldwide. Surgical site infection is the most frequent type of healthcare associated infection in low and middle income countries and affects up to 1/3 of patients who have undergone surgery. It triggers 7 to 11 extra post-operative days in hospital, sometimes even longer, and results in 2 to 10 times higher risk of death than comparable non-infected patients. Up to 60% of SSIs are prevented, can be prevented, and let's see how we can do that. If this is how a typical OR in which you are entering looks like, you are begging for HAI, but let's see how we can prevent it. So the purpose of having infection control practices is to prevent post-operative infection, prevent infection transmission from patients to staff, instruments, equipment and environment, because the same instruments, equipment, environment is going to be reused. It is pertinent to all personnel who are involved with the surgery, equipment, instruments and environment, all patients and their beds and equipment brought in and out of the OR, and anyone and everyone involved in surgery and or in direct contact with sterile equipment used invasively or on usually sterile mucous membrane. What are the sources of surgical site infections? They can be either endogenous, that is normal flora of the patient's skin, mucous membrane or viscera, and exogenous, that is surgical personnel, the operating environment and tools, instruments and materials brought into the sterile field during operation. As far as personnel are concerned, what are the asepsis practices that are supposed to be used as per the guidelines? Staff, including all surgeons, must remove all jewelry, change into theatre clothes and shoes before entering the clean zone. There are times when we are sometimes lax about this and we say chalta hai, but that's not what is allowed. Staff is expected to spend at least 1 minute at the scrub area washing their hands thoroughly and then drying them properly. Drying hands is also important. The aseptic zone of the OR should be restricted just to the personnel involved in the actual operation. A fresh mask for each operation, disposable linen caps for all staff, and scrubs worn by patient caretakers comprising of surgical team, scrub nurse, anesthetist should be clean and sterile. It should be steriled by autoclaving. And linen should be changed after attending an infected case in the OT. So this is important for some inflammatory cases that we operate, especially TB. Protective eyewear should be preferably worn for all cases, especially the ones in which there is spillage expected. Wear sterile gloves after wearing the sterile gown without touching the outer surface of the glove. For short visits to the OT, for people like the photographer, physician, maintenance staff and some people who may just come in for some time, they have to change to OT attire. You can't be lax there. For urgent immediate attention to a sick patient or a crash situation, people coming in from outside may not change immediately, but then should put on disposable gowns or proper OT dress as soon as conveniently possible. People from the OR who go outside, maybe to get blood or to give specimens for frozen or something like that, should wear a clean apron, gown and outside shoes before leaving the OT complex, and then while coming back again change into the appropriate attire. The sterile field should be maintained at all costs. Sterile personnel should not reach to unsterile areas or touch unsterile items and vice versa. Coming to cleaning and disinfection, surfaces in the OR must be routinely cleaned first with detergent to remove any foreign and organic matter, and disinfection should then follow cleaning. Do not apply disinfectant directly, as organic matter such as pus, blood, urine, etc. inhibits the action of the disinfectant. A detergent disinfectant combination also can be used, and any spills during the surgery as far as possible must be cleaned immediately. Disposable or freshly laundered washable cloths or mops should be used with freshly prepared solution for each of these tasks. How frequently should the OR be cleaned? Sometimes it is cleaned too frequently, sometimes too less frequently. So OR should be cleaned once daily, and the entire theatre complex, that is deep cleaning, once a week. The schedule for cleaning the OR should be before the first case, that is the beginning of the day, during a surgery, between surgeries and at the end of the surgery. Post weekly cleaning, the infection control nurse has to take culture swabs and make sure that those swabs are seen and they are negative before the next OR schedule. This is how the OR should be designed. So there has to be a protective zone, a clean zone, aseptic zone and disposal zone, and there has to be appropriate attire for each of these zones, and they should be strictly followed to prevent post-operative infections. Coming to CDC recommendations for preventions of SSI, they have divided these recommendations into 4 categories. 1A is strongly recommended for implementation and supported by well-designed experimental, clinical or epidemiological studies. 1B, which is strongly recommended for implementation and supported by studies and strong theoretical rationale. Category 2 is suggested for implementation but only theoretical rationale, and category 4 is no recommendation or unresolved issue. And they have divided these recommendations into preoperative, intraoperative, postoperative and surveillance. So in preoperative, it comes to preparation of the patient, hand asepsis and antimicrobial prophylaxis. How do we ideally prepare a patient for surgery? So identifying and treating all infections remote to the surgical site, something like UTI or some other infections, ideally should be dealt with before planning at least an elective operation. If needed, remove hair immediately before the procedure, preferably with electric clippers instead of the razor. This is a standard guideline. Require patients to shower or bathe before with an antiseptic agent at least the night prior to the surgery, and thoroughly wash and clean at and around the incision site to remove gross contamination before performing skin preparation. So scrubbing is utmost important. Hand asepsis I have already spoken about earlier. Coming to antimicrobial prophylaxis, so administrating an antibiotic only when indicated, that has got 1A evidence, and administer by the IV route the initial dose not more than 1 hour before the incision. So this timing is also very important. Intraoperatively, the ventilation system of the OR, cleaning and disinfection, sterilization of surgical instruments, surgical attire and drapes, and asepsis and the actual surgical technique plays a big role. Positive pressure ventilation has to be maintained in the operating room, 1B. Maintain a minimum of 15 air exchanges per hour with at least 3 fresh air exchanges. This is important especially for cases like ours where we deal with airborne infections. Do not use UV radiation in the operating room and keep the operating room's doors closed except as need for passage of equipment, personnel or the patient. Coming to the actual asepsis and the surgical technique, alcoholic solutions are preferred over aqueous solutions for skin preparation. Single-use sachets of solutions, not multi-use bottles. This I know practically may not be possible every time, but that's what the guidelines say. Wound should not be drained unless necessary. Now this is rarely possible in thoracic surgery unless you are doing probably a tubeless VATS, but the percentage of those surgeries, at least in India, is very small. If drainage is used, use a closed suction drain, insert it through a separate incision distant from the operative incision and remove it as soon as possible. This is not possible only in uniportal VATS because we usually put the tube through the same incision, but other than that, this is always possible. Coming to some specifics for inflammatory lung surgery, especially TB patients who are sputum positive when we take them up, although it's a small percentage. The surgery should either be postponed if feasible until the TB patient is no longer considered infectious. This case should be scheduled if possible as the last case so as to allow adequate ventilation of the room after surgery. Air supplied to the operating room should be exhausted to the outside, so there has to be a separate exhaust, and that air should not be mixed with other patient areas of the hospital. Everyone in the OR should wear appropriate respirators, at least N95 if not the bigger respirators. Post-operative recovery of the patient, that is the immediate post-op recovery, should take place in the operating room itself or in a AIIR, that is airborne infection respirating room. This is as per the 2012 NWT Infection Prevention Control Manual. The OR must be on negative pressure of -25 or lower with separate ventilation. Air in and out must be disinfected and filtered. So HEPA filters are considered as gold standard. The OR should have a designated disinfection room with instrument washer and autoclave. So these instruments ideally should not be mixed with the other instruments in the OR complex. All waste and fluid from the OR should be disinfected as required, and temperature in the OR should be maintained between 21 to 25 degrees Celsius. At the end of the procedure, a warm saline plus povidone iodine plus hydrogen peroxide wash will help to minimize post-operative surgical site infection. Dr. A.V. Baliga, by whose name there is an institute in Udupi, Karnataka, very senior surgeon. This quote of his has been mentioned in Dr. Udvadia's autobiography, which I was recently reading. And what he said is that post-operative care is best done intraoperatively. So to summarize, infection control addresses factors related to the spread of infections within the OR, patient to patient, patient to staff, staff to patient, or even amongst the staff, including prevention, of course. Integrated infection control in the OR has various aspects ranging from designing, cleaning, management of biomedical waste, and adherence to attire. Proper designing of the OR, appropriate microbiological monitoring, proper sterilization, and strict adherence to barrier techniques form the basis of preventing infections in the operating environment. Now that we have summarized all this, we would be able to go back to this picture and see what all was wrong in this OR, and let's try and avoid all this and keep our ORs infection free and our patients rid of post-operative infections. These are the references for my talk. Thank you.
Thank you, Dr. Amol. It has been a very lucid presentation, I would say. And just a comment, are these guidelines only there for thoracic surgery, or they are the same for all types of surgeries which carry out in an operating theatre?
There are very, very few guidelines which are specific for thoracic surgery. These are general OR, most of these are general OR guidelines. Only the NWT guidelines, there are specific guidelines for TB surgery and inflammatory surgery.
Just a question for that. In your presentation, you have mentioned that the temperature maintenance should be between 21 to 25 for tuberculosis surgery. Any specific reason why this range?
Colder the environment, colder the temperature, higher the risk of infections is what the guidelines say.
But is it specific for tuberculosis or for all types of surgery?
No, for infective, for airborne surgeries where airborne infection is possible.
Fine. Any questions? Yes, Dr. Rajat.
Yeah, Amol, you said that post-operatively you wash with saline, hydrogen peroxide and betadine. So hydrogen peroxide used directly, or you sterilize hydrogen peroxide by some method? Or you can use it directly from the bottle and put it in the patient's chest?
You can use it directly from the bottle, but try and use a separate bottle for each case.
Okay. You need not sterilize the hydrogen?
No.
Now, one of our chairperson is Dr. Manpreet Bhalla. She is a microbiologist. I request to comment something about.
Yeah, thank you very much. It was a very elaborate presentation.
Thank you.
We covered all the aspects, and as pointed out by Dr. Vora, there are no specific guidelines related to surgery, thoracic surgery only, but it's in general for all the surgeries. So just to again say the points, the salient points which are required to prevent the infections in the operation theatre, as you said, because mostly the infections are spread from patient to doctor or patient to patient. So it is very important that between the two surgeries to disinfect the site. So that will reduce a lot to the incidence of the infections. Secondly, depending on the type of organisms, if you have a particular patient, you know that what type of infection like MRSA or VRE or clostridial infections. So depending on that, you can, if you can do the processes thinking about the organisms beforehand, so that will help. Then again in COVID and other viral infections, it was said that all the OTs, we should not have central ACs.
Right.
Because of the circulation and all, and you require at least 15 air changes per hour. And preferably actually that time the OTs were asked to be adapted with HEPA filters and all. So, but it's not always possible, but wherever possible, and at least negative pressure should be there. And last thing is that since the antimicrobial resistance AMR is increasing a lot, so we have to be very judicious in the use of antibiotic, as you already said. So only if it is very urgently required, if you feel that it's absolutely required, and also after the surgery, as you can do the weaning based on the microbiological report also. And the question is that in your center, what are the microbiological techniques which you are following in routine for the surgery OTs for microbiological testing? You order before any surgeries? Any
Microbiological surveillance of the theatre.
So
how frequently you send the culture and what culture?
We send weekly swabs from the OR for culture.
So what is your recommendation, madam?
Can I mention one point, Amol? Today, in today's day and age, we use a lot of endoscopic equipments like thoracoscopes, endoscopes, bronchoscopes, and their sterilization, I think, is another thing which should be stressed upon, specific in the context of thoracic surgery, that this may not be sufficiently done by our SIDEX solutions, etc. And most of these units should aim to acquire plasma sterilization techniques.
Sir, for bronchoscopes and all, I agree with what you say. But for the VATs, the scopes that we use, they are autoclavable. But not all centers strictly autoclave the telescope, which should be made mandatory. That the autoclaves, the telescopes have to be autoclaved.
It's very important actually. Sometime in the very busy center, if you are doing the bronchoscopy one after another, and then hardly any sterilization of scope in between. So in that situation, how to quickly sterilize it?
So if it is a very, very busy center, maybe you will have to have 2 sets or something and then plasma sterilize in between. That is the ideal way to do it.
I think the SIDEX has been banned by the, as per policy in all the hospitals. I mean, by NABH, SIDEX is not used anywhere. And the formalin chambers have been banned long back. So I think the only thing is the plasma and or the steam sterilization for all the equipment. And another thing I want to mention about the, the COVID-related patients when we are operating on the chest, and there is an air leak there, that the air leak which is coming from the chest bottle is directly infecting the patient. So we were using a filter at the end or directly connecting it to the negative suction so that the air in the room is not contaminated, particularly in the post-operative period.
Right, sir. Also adding one thing to what Madam was saying, that I think every hospital should have its own antibiogram. So that will help in judicious use of antibiotics.
Yeah, it's very important to have the antibiotic surveillance.
Thank you so much.
Thank you, Dr. Amol. Would like to invite Dr. Ajay Narsinhan. Okay. He is a consultant thoracic surgeon in Madras Medical College, and his topic for today is the post-pneumonectomy complications. Okay. Okay, Dr. Nasir Yusuf. He is an associate professor and a head of department at minimal invasive thoracic surgery at Sunrise Hospital in Kochi. And he will be talking about, so you talk.
I'll manage. Thank you. Thank you,
Chairperson. Please do.
Since for COVID, Yeah, good afternoon, everybody. I'll try to keep it short like a mini skirt, long enough to cover the essentials, but short enough to arouse the curiosity. This is an area unforayed, the fear of the unknown, and early stages of COVID. At that time when surgery was considered, no guidelines existed for these lung COVID, post-COVID lung complications. There was lack of evidence, there was or precedence. The huge enormity of the situation has already dawned on you. What we normally see in these patients are, in addition to the classical scenario, are pneumatoceles, which interest the surgeon, parenchymal air-filled cysts, aspergillomas. But another critical point is pulmonary vessel thromboembolism, requiring anticoagulants, which can lead to intrapleural bleeding. Moreover, these patients often develop co-infections which lead to further complications such as empyema and septic shock. All these conspire to cause adverse events. Please note, these issues are not limited to patients who suffer from severe COVID, but are also seen even in those with mild form of infection. We are all, as thoracic surgeons, aware the aforementioned conditions could be managed by a surgical approach. But many experts advised at that point of time against any referral to surgery in COVID-19 patients based on then published data reporting high early postoperative morbidity and mortality. This is for patients who have had COVID but not a thoracic COVID lung complication surgery for other conditions in the body. This emanated from the COVID surgery collaborative group, which set up the largest observational study considering an international sample of more than 1,000 SARS-CoV-2 positive patients undergoing emergency and elective surgery. This showed a mortality rate of 23% and pulmonary morbidity rate of 51%. There's a saying, fools rush in where angels fear to tread, and we, at that time, in a point, probably in a moment of weakness, received a call from Udaipur, R&T Medical College Professor Mahendra Kumar saying that but एक बच्चा है 17 साल का लंग फटा हुआ है तो मैंने कहा क्या प्रॉब्लम है लास्ट में कहा it's post COVID, and those were times when surgeons shied away from all these kind of conditions. Anyhow, to cut a long story short, he came across all the way from Jalore, Udaipur, Ahmedabad, and reached Cochin. Next was the problem. How to overcome resistance to change. We are challenging the existing statements, saying that now we need to convince the anesthesiologist, the intensive care team, and the hospital, can we do a COVID positive, post-COVID complication, which was hardly recovered within a week. And this condition was deteriorating, needless to say, with couple of chest drains. But in the end, diplomacy prevailed. Now, what's the rationale from the surgical point of view? Lung fibrosis is the main reason for shortness of breath, and if generalized, medical management, no question about that. And otherwise, lung transplantation. Where do we come in? But if on CT scan there is localized disease, such patients may be candidates for surgery and recovery. That was the basis, the logic, the foolish step we took. And over a period of time, burning our fingers, a certain picture emerged, and we could help patients who had localized pneumonia, non-resolving, not responding to the classical, usually it's Klebsiella and staph, not responding to vancomycin, linezolid, or cephalosporins, and quinolones. Those cavity, aspergilloma, COVID-associated pulmonary mucormycosis, empyema, BPF, infected pneumatoceal, bulla, localized bronchiectasis, and pulmonary thromboembolism, all these can benefit from surgery. Now, this is a patient, you're familiar with empyema, multiple abscesses, and this is what we see normally on thoracoscopy or VATS. However, we had a patient who was just blowing pneumothorax, COVID, post-COVID, with no idea what was wrong. So, just out of curiosity, and remember the saying, curiosity killed the cat, and information made him fat. So, seeking that information, we put in a scope in the ICU, patient on the ventilator, just to see what was happening. And we were in for a most unpleasant surprise. This was the lung, actual lung, a gray hepatization with multiple holes. Obviously he died. So again, coming back to where we can help them, localized pneumonia, not responding to antibiotics, cavity and its complications, enlarging cavity, fungus sets in, aspergilloma, hemoptysis, the rest. And then, of course, black fungus, which is quite common I would say, inverted commas, in the north, unlike in the south. Mucormycosis, where normally affects the paranasal sinuses, orbits, brain, GI, and also the lung. A multimodality treatment approach, antifungals, posaconazole or amphotericin, and then surgery. And this is one of those cases where you find a mucor excise. We did a lobectomy in this patient. Post-COVID empyema, BPF, as Dr. Jain had mentioned earlier, is not very uncommon. This patient was presented because we did the surgery, patient recovered, everybody happy, went home. 5th day, the guy again blew a bronchopleural fistula. We then went in and bronchoscopically put a spigot and controlled the air leak. Unfortunately, within 2 weeks it was out, and we took out the spigot in a month. I would pause here for a moment and appeal to my youngsters and colleagues. We need to move in. We know fiber optic bronchoscopy, we know rigid bronchoscopy, we know thoracoscopy. We should enter the domain, which is now being taken over completely by the interventional pulmonologists, for 2 reasons. One, our borders are shrinking. Second, we come across as a poor impression to the patient when a complication a surgeon cannot deal with. So I appeal to you, food for thought on this aspect. Of course, bronchiectasis localized can be dealt with. Pneumatoceles, quite common. As pulmonologists, some of you would know, the importance of the pneumatoceles is most of them can be managed medically. Some continue to enlarge, rupture, and then trigger pneumothorax, pneumomediastinum, and pneumopericardium. So the size of the pneumatoceles which rupture is again variable. It could be a small one, which or a large one, and some of the large ones fall into the category of bullae. These can be excised with good result, allowing the rest of the lung to expand, and the exercise tolerance improves. This is a classical bulla which you see in emphysematus patients. However, in post-COVID lung, it's a rapid appearance, and it's multiple, almost replacing that particular lobe, and appears like a bunch of grapes. The challenge therefore is different. Pulmonary infarction, this is a borrowed slide from our study, an international study we had done. As you can see, the CTPA shows filling defects on both sides. Infarcts on both sides, not very significant. If you have iodine maps, that will help you localize the lesion, excise it, problem solved. So at the beginning, we had more questions than answers, but over time, it has come down to why surgery, more or less explained. Who is the candidate? We are getting there. Where to do, we know. When to operate, again a gray area. What is the outcome? We'll see. This study was to let you know that when can we operate. These are broad guidelines by the American Society of Anesthesiologists and the APSF. What they found for us is pulmonary function continues to improve up to 3 months. So basically, delay it as much as possible unless the condition deteriorates. Investigations have been beautifully mentioned by Dr. Anil Kapoor. We laid a lot of emphasis on the stair climbing and ventilation perfusion scans. And then all this effort, colleagues of ours across in Brazil, Italy, UK, and the US, we came together and published, after much resistance, the first international multi-center study in the world. The numbers were fewer then, 83, as we listed: pneumothorax, empyema, hemoptysis, lung abscess, infected pneumatoceles were addressed, and the important point was 72% were alive after 30 days. And re-exploration was done for various reasons. There is time terrorism today. Even in this hall, there is terrorism, of time terrorism, so I have to rush through. And this is our data in the last, from July 2022 to September 22, and importantly, we have a survival rate of 90%. It's not that we have done magic. Why? We excluded. We never touched them. Patients on ECMO, patients on ventilator, patients on anticoagulants, patients having moderate to severe pulmonary hypertension, and we had our share of complications, mortality, and the sad part of the mortality was, I will draw your attention to, was a patient walking, collapsed suddenly in the ward, pulmonary embolism. We had taken all the preventive steps like intermittent pneumatic compressions, and my dear friends, there are no strict, no definite guidelines, any paper you do or any research on how to avoid prophylaxis for pulmonary thrombosis in thoracic surgery. Outcome, quality of life, lung improves, quality of life improves, patients can ambulate with minimal or no requirement of oxygen, thus converting them from respiratory cripples to productive human beings. They are relieved from symptoms like cough, breathlessness, hemoptysis, fever, etc. VATS is preferred outcome, was a significantly, that's what we found to thoracotomy, but ERAS says something else. Well, each one is entitled to their opinion and their observations. And so finally, trying to cut it all down short, surgical management of COVID-19 related thoracic complications is affected by relatively high mortality and morbidity. However, 72 to 90% is encouraging with a salvage intent. Further, patients who underwent surgery for infective affections, empyema, infected pneumatoceles, lung abscess, had a significant lower risk of dying, so safer to take them on. Younger patients with no pulmonary hypertension, without renal insufficiency, please note, without it, with your creatinines being normal and undergoing surgery for infectious complications, again seem to have a better prognosis. And to reiterate, these issues are not limited to patients who suffer from severe COVID, but also seen in mild forms of COVID. So, younger people, younger generations, more brave, more bold, overcome the fear of the unknown, which is what is resistance to change. Think out of the box, and you be the change, the thinking surgeon. Thank you.
Thank you, Dr. Any question? One question I asked Dr. Nasir, what surgery you did in lung abscess and pneumatoceles?
No, that's local resection. We see the problem with COVID, however the CT scan might look better, there is inherent fibrosis. So minimum resection, maximal lung sparing.
So how you do lobectomy?
At times lobectomy, mostly wedge resection.
Large lung abscess.
Yeah, large lung abscess sometimes.
Not less than lobectomy is.
Large lung abscess, yes, lobectomy. We do a lobectomy, and a ventilation perfusion scan helps us to predict the postoperative function.
So, what are the indication of surgery in the lung abscess? The fever is subsided and the antibiotics, and patient is now normal. Still, you operate upon him?
No, we don't.
What are the indications?
We don't. If the patient has lung abscess, symptomatic, we don't venture into that area. Why trouble him? And we don't know how these lungs will behave. The problem comes when they go onto the ventilator. No, during surgery, they are on the ventilator. So that can cause dreadful harm. So it's a catch-22 situation. You have to weigh the risks and benefits, and it's a large area we are still unaware of, the outcomes after that. So ventilation is critical that we extubate as early as possible.
And in pneumatoceles?
Pneumatoceles, we do the resection. If the patient is enlarging in size, become breathless, his condition is deteriorating, exercise tolerance becomes less, and that's just like a space-occupying lesion, deal with it. Most pneumatoceles, as I had mentioned earlier, respond to medical treatment. Enlarging pneumatocele, increasing symptoms, do not wait, it could rupture and has its own problems, pneumomediastinum, pneumothorax, and all its complications.
Thank you. Yes.
Nasir, it was a nice study. I have gone through that paper as well. Since these patients were having more of a fibrotic changes post-COVID, did you find any difficulty in expansion of the lungs after decortication or after lobectomy? I mean, more space problems than ordinary ones?
Yes, absolutely. We have basically three types of lung we operate on. One is a tubercular lung, then the post-radiation lung cancer, difficult surgeries to perform, and this entity, which is almost behaving like tuberculosis patients, refuse to expand at times, and then you have all those lovely suction machines which we need to employ and use.
And in the longer term follow-up, do these patients, has some long-term problems as well because of the fibrosis or, any problem with the ventilation, perfusion, mismatch or something after operation, or they just, overcome their fibrosis over a period of time?
Now, see, we cannot predict how much they'll overcome. Just like which patient will have severe fibrosis after COVID, here we are dealing with a problem which is critical. So we remove that area and the patient improves. And then what happens, some of them come back, most of them go back to normal life, off oxygen and go back to productive life. Hard labor, questionable.
So all the patients, most of the time, you operated, they require sort of a emergency or semi-emergency surgery.
Yeah, most of it, we wouldn't, not exactly, see, we would push it as much as possible, 3 months. Because that's the understanding that lung fibrosis reaches a maximum recovery within 3 months is the understanding. So push it as much as you can and then take them up for surgery.
Thank you.
Congrats, Dr. Nasir, such a beautiful study, and probably there are very few studies for post-COVID surgical patients. I don't know how many studies are there from India. I would just like to ask you one thing. Suppose you have a patient post-COVID pneumothorax, you put in an ICD, and there is a persistent air leak. Now, what would be your approach? You put in a scope, you see there is some rent in the lung. What do you do?
Yeah, we would attempt to close the bronchopleural fistula.
So you would do a
or resect that area out.
Wedge resection,
yes.
or what?
Yeah.
Wedge resection.
Sure.
Because lung is very fibrotic in these patients. So would it be possible to do a wedge resection?
See, you are not in the acute phase of COVID.
Mm-hmm.
If the lung is recovered and is recovering, may not be normal. So there is a risk of health. Yeah.
What I want to ask is that suppose it is a post-COVID patient with pneumothorax, suppose 10 days or 15 days after the fever and everything has subsided.
Yes.
Patient is leaking.
True.
Chest tube is there. Now what do you do?
If he is not stable, he continues to have fever, going ahead with sepsis, go in. It's a life-saving operation.
Nasir, just one question. See, the indications which you have put up over here for COVID, these are the indications we would be normally seen in non-COVID patients also.
Correct.
Right, so you are basically operating for them. So what is the difference you are finding when in mortality, morbidity, when you are doing in COVID and non-COVID patients?
See, exactly, that's where gave us the inspiration to go in for these patients. Normally, we will operate these patients. Just because he is COVID and widely accepted COVID patients have a poor outcome, people were afraid to operate on. Everybody is worried about their statistics as well. So the recovery rate definitely, that's the reason we found that 70%, 90% mortality, survival rate. The mortality and morbidity is greater with COVID patients as compared to other patients having infective pathologies.
So you would get similar results if you had dealt with non-COVID and COVID also?
Sorry?
You would have got a similar morbidity and mortality in a
No, morbidity is much more in COVID.
Much more in COVID, these sort of patients?
Yeah, absolutely. Without doubt. Point well taken.
I thank you. Thank you, Dr. Vasid. There are no more questions. So, we go on to the next speaker. Is Dr. Ajay only? Dr. Ajay. Nursing Simha.
Dr. Ajay Narasimhan is a consultant thoracic surgeon, Madras Medical College, Chennai. He will be speaking on the post-pneumectomy complications.
Thank you, sir.
And
good afternoon.
Management.
At the outset, I'd like to thank the organizing team comprising of Professor Ravindra Diwan, Dr. Pallavi and Dr. Saransh for having me over. We have had a host of topics over the past 2 days, all ranging from hi-fi, but sometimes it's always nice to listen to grandma stories like that post-pneumonectomy complications. Even though it's an age-old topic, keep repeating all over again, it's very important. So, this is where I work, Madras Medical College, one of the oldest medical colleges in Asia. If you haven't had a complication, you aren't doing enough, or I leave it to your imagination, you are maybe fudging statistics, you're lying, or you're not telling the entire truth. So, when do you all do a pneumonectomy, or what is a pneumonectomy? It's like removal of an entire lung, and mainly done in malignancy when there is a mass across a fissure and a difficult location in the right bronchial tree, even though there are a lot of techniques now to preserve the parenchyma, and sometimes for clearance you might have to do a pneumonectomy. But in our practice, mostly for inflammatory diseases, destroyed lung due to tuberculosis with hemoptysis, and then a big BPF and all that stuff. So sometimes we are forced to do a pneumonectomy in the intraoperative period because of we are not able to get away with smaller resections. So what are the expected changes that happen once you remove the lung on one side? Immediately there is air in the hemithorax, and slowly there is a hyperinflation of the opposite lung, and this is very important for postgraduates. I am not very sure how many postgraduates are here, but still, hyperinflation of the opposite lung, and there is elevation of the hemidiaphragm of the same side, and a mediastinal shift is there. As all these happens, progressive resorption of the air occurs and replacement with fluid. The fluid is replaced as up to 2 intercostal spaces per day, and finally the entire hemithorax gets opacified and it becomes all right. So these are not my X-rays, and got it from the article on UpToDate, a beautiful article about post-pneumonectomy changes. The expected radiation radiographic changes in the early post-pneumonectomy period. So 48 hours after surgery, fluid accumulates quickly, and if you can see the delayed post-pneumonectomy changes due to the hemidiaphragm is elevated, and even though you can see the liver in the thorax. So when any patient comes to you with post-pneumonectomy, suspect any fluid, without an ultrasound, now it's almost mandatory not to go in even for pleural effusion without an ultrasound, image guided. So we should be very careful. You can enter the heart, the needle can enter the heart, the needle can enter the liver, spleen, wherever. You should be extremely careful. And this is on the left side where you can see the spleen in the post-pneumonectomy space. And what happens to the post-operative pulmonary function? Generally, forced expiratory volume and forced vital capacity decrease by less than 50%. The diffusing capacity for carbon monoxide also decreased by less than 50% and is usually normal when corrected for the lung volumes. The lung compliance definitely decreases and airway resistance increases, and dead space may either increase or decrease. The usually PO2 and PCO2 at rest are normal because there is little or no disease in the remaining lung. Only those patients are generally subjected to pneumonectomy. And cardiac functions, the right ventricular ejection fraction decreases and the end diastolic volume increases, and the LV function usually does not change, but there are some studies which say LV function also decreases. In all patients, the heart rate was elevated and stroke volume was low. As long as the remaining lung is relatively normal, the cardiac function is not affected to a great extent. So, coming to the main crux of our topic, the complications, you can split them into general complications and organ-specific complications, and the other way of classifying them is the early complications and the late complications. We are not going to go about the general complications, we are going to see much about the organ-specific complications. So, and as we see the complications, we will be able to classify whether they are early or late. So, what are the 30-day post-operative mortality is up to 6 to 8% in a pneumonectomy, right being greater than the left. What are the risk factors? As there are 3 good articles, but these are all predominantly for malignancy. Advanced age, cardiovascular disease, right pneumonectomy per se is a increased risk factor for mortality after pneumonectomy, and when the patient has received preoperative neoadjuvant therapy, not adjuvant, preoperative neoadjuvant therapy, sepsis, respiratory failure, when you have disease, some disease in the opposite side, or sometimes intraoperative soiling and all that, and then extended resections and male gender, they are all high risk factors for pneumonectomy, post-pneumonectomy mortality and other complications. So, let us see the pleuropulmonary complications following pneumonectomy. First one is the important complication is pulmonary edema. Post-pneumonectomy pulmonary edema is seen in 2 to 5% of patients. It is 3 times more common in right than the left. The pathophysiology is believed to be like that of an ARDS, and it usually occurs within 72 hours after the surgery, and mortality rates exceeds 50%. One way which has been thought to reduce the risk of developing PP, post-pneumonectomy pulmonary edema, is by giving methylprednisolone 250 milligram just before you ligate the main pulmonary artery. It may decrease the risk. No proven studies, these are all just anecdotal reports. And post-pneumonectomy syndrome is a very, very important topic for the postgraduates. Extrinsic compression of the distal trachea and main stem bronchus and the mediastinal vessels also, main vessels also, mainly due to the mediastinal shift and hyperinflation of the remaining lung. It can occur up to 6 months after surgery and also been reported up to 35 years after surgery. It presents with progressive dyspnea, cough, stridor, and fatal if untreated. The management involves mediastinal repositioning and keeping some tissue expanders in the mediastinum and allowing the mediastinum to go back to the normal position. Maybe saline treated breast implants are being used. There are rare variants of PPS where esophageal compression may cause the dysphagia and pulmonary vein compression causing dyspnea. Ultimately, you have to reposition the mediastinum. That is the most important part of it. And intraoperative spillage, earlier it was very common, but with the advent of flexible fiber optic bronchoscopy, it's almost not existent now. It's common in suppurative lung disease and can result in death on table because you have removed one lung and the remaining only lung, it's going to be soiled with secretions, then we are in deep trouble. It can also result in postoperative respiratory failure. Prevention is key. And post-pneumonectomy empyema, it's 5% of pneumonectomies go on to develop this. Early empyemas 10 to 14 days, they are usually associated with bronchopleural fistulas. Late empyemas are affected through the hematogenous route more than 3 months after the surgery. The shift of media, you can recognize this on radiographs by the shift of mediastinum away from the operated side as opposed to the same side. And new air fluid levels occurring and change in fluid dynamics. What was white earlier is now going to become black. What was black now becoming white and all that. The mainstay management includes drainage of the post-pneumonectomy space, sterilizing the space, and treatment of the bronchopleural fistula if you have any. But as I told you, drainage should be done under guidance, ultrasound guidance, because you shouldn't end up putting an ICD in the heart. There you can see a nice opacified left pneumonectomy space, suddenly complicated when air fluid level. You should always think about pneumonectomy, post-pneumonectomy empyema associated with bronchopleural fistula. And empyema is always discussed along with BPF. 1.5 to 4.5 incidence in the post-pneumonectomy with mortality ranging from 29 to 79%. Within 1 week of surgery, it's generally not associated with empyema and can be repaired primarily, at least given an attempt, but not so in inflammatory lung disease, really bad cases. Delayed onset BPF almost always associated with empyema and more common in right-sided procedures, large diameter bronchial stumps more than 2.5 centimeters, long stumps if you're going to leave, and in malignancy patients post-chemo RT. And if you're having active infection, tuberculosis at the bronchial stump, the risk of BPF is very high. And if your patient gets stuck on a ventilator post-operatively, again, risk of developing a BPF is very high. The management, I'm not going into detail, I'm just touching upon the salient aspects. The management involves confirming the BPF. BPF is almost obvious, but still you'd like to do a bronchoscopy just to see how big the BPF is. And space, it involves two parts. One without the other is going to lead to treatment failure. You have to manage the space either by sterilization and obliteration, and fistula management can be done by a transthoracic approach or a transternal approach. But as I'm telling you, prevention is always better than cure. There have been a lot of studies and now it's almost proven that stapling is better than hand-sewn bronchial closure. It reduces the incidence of bronchopleural fistula in the postoperative period, and if possible, always better to reinforce with flaps, intercostal, pleural or pericardial pad of fat to maintain a vascularity of the bronchus. So this was a patient of mine, very sad, SLE with high steroids. She underwent bilobectomy first. She developed a BPF. We had stapled it. Then you can see the right main bronchus is basically just feeding into the pleural space. And she had a very prolonged course in the hospital. And then she underwent a completion pneumonectomy. And this is the post-pneumonectomy. Again, she developed a BPF. She had a prolonged course and now she is all right. But we have, I don't know, we have not had a follow-up in the recent past. And other uncommon things, esophagopleural fistulas following right-sided procedures. Residual tumor, if it is there, then I think it's best to leave it alone. And the mortality approaches almost 65%. And chylothorax, following extensive lymph node dissection, either for the esophagus or for the lungs, you can injure the lymph duct. And asymptomatic patients with very slow accumulation of chyle I think it should be managed conservatively by the medium chain triglycerides and all that, dietary modifications and all that. But if possible, thoracic duct embolization can be done better than going in again and meddling in the post-pneumonectomy space. Thoracic duct embolizations have shown very good results in our hospital. We have good series of thoracic duct embolizations by our interventional radiologists. They do a good job of that. An acute hemothorax, as we all know, it is bleeding. It can be due to slipping of knots, clips. We were discussing in the morning also. The best thing would be to go in and re-explore. And again, I'm telling you, all these complications are better prevented rather than addressed. Prevention, you can try stapling if possible, if you have the affordability to do a stapling even in open surgery, or if you are doing knotting, better to reinforce with Prolin on arteries and veins. And contralateral pneumothorax, it's not uncommon. There's usually a preoperative herniation when there's a destroyed lung on the opposite side, and when there are bullae and blebs in the opposite lung, giving positive pressure to one lung can result in any pneumothorax. Management is like any other pneumothorax, put in an ICD, but you have to have a high index of suspicion, and if unrecognized, the mortality can go up to 50%. And cardiovascular complications, you have arrhythmias, myocardial infarctions, and pulmonary embolism. The arrhythmias, atrial fibrillation is the most common. These patients are more prone to complications and increased hospitalization and costs. The role of prophylactic agents is still under investigation. There is no one paper that clearly shows the benefits or the risks of prophylactic and rate control agents. Similarly, pulmonary embolism is another deadly complication. The mortality can go up to 60% in the post-operative period. Intracardiac shunting is very rare. I have not seen a case in my limited experience, but right to left shunt can occur through a PFO and 2 to 3 days after surgery. Cardiac herniation, again, if you are going to do an intrapericardial pneumonectomy, always try to close the pericardium before you come out. Miscellaneous complications are many, but one thing which we commonly see is post-pneumonectomy scoliosis. Because of the space, the acquired scoliosis happens. And very, very rarely you can get a post-pneumonectomy paralysis due to intercostal artery injury and all that stuff. So, in conclusion, there's a whole spectrum of complications. Whatever you want to see, you can see in a post-pneumonectomy thing. Surgery might be easy because there is only 4 structures. You're just going to either sew them or staple them. But the post-operative period isn't. You have to be very, very careful and watchful in the post-operative period. Always prevention is better than cure. Minimally invasive approaches are better than open. If possible, try to do a VATS or a robotic approach because the complications are lesser in the minimally invasive approaches. Post-pneumonectomy, the patients always have a lower quality of life than the segmental resections. So, always better to try to avoid a pneumonectomy if possible and go in for a parenchyma preserving surgery. With this, I'd like to conclude my talk and take any questions. Thank you.
What is the appropriate time of intervention? You encountered bronchopleural fistula post pneumonectomy. What is the timing of intervention? When you will intervene?
So when there is an active infection in the space, I think we should wait for the space to get sterile. That's why the bronchopleural fistula management following pneumonectomy should be divided into 2 parts. One is the space management and the fistula management.
So what do you do for the space and what do you do for
space? We have to drain the space generally we put an ICD under guidance, ask our radiologist colleagues also and put an ICD, and we have to do an antibiotic lavage if possible. So we need to sterilize the space and then only we have to take him up for surgery because
go and clip the bronchus again.
No, so again through the thorax, if you are going to go in and clip the bronchus, it's going to give way. So, if possible, we have a series of 6 patients where we have gone through the sternum, transsternal, transpericardial clipping of the right main bronchus.
What is yeah.
So first drainage is better. When he says sterilizing by liquid solution, that should also be done carefully. You can infect the other lung also. And what we actually have seen that generally in post-inflammatory lung conditions after pneumonectomy, one has to do a window thoracostomy later on, 2 months later, and 6 months down the line a thoracoplasty because there is no lung. And but when you say one thing that pneumonectomy should be avoided, I ignore pneumonectomy should be avoided, but we in inflammatory conditions, suppose you have done a very difficult right upper lobectomy and there are lesions left in the right lower also, and if you have to leave a disease there, it causes greater morbidity to the patient than doing a pneumonectomy. That has been my overall experience, though it does not match what the literature says. So that's a point of some difference. But overall, I think he has covered all the points very well. Thanks.
Thank you.
Thank you.
One thing, probably because we don't have interventional pulmonologists here, they put spigots. They put, and it works pretty well.
Cyanoacrylate.
PPF, sorry? No, they put large ones. Valves they put.
But it
So
just
that's
slips
coming
into
up.
the pleura.
Sorry?
It will go and slip into the pleura, no? Sir?
No, the large, see, the BPF could be a small one. See, it depends on the size. It's not the whole bronchitis is burst. But you can, if the BPF is not very large, they can put this and block it. And they've done it. So this is one thing we can keep in mind, as long as you have the whole stump which is ruptured.
Excuse me, I have one question for the post-pneumonectomy syndrome. So I am a chest physician. So we sometimes see these post-pneumonectomy patients. So one, you said there is a post-pneumonectomy syndrome which can be diagnosed by the CT scan. But there is a one variant which you say is compressing the pulmonary vein. So how do you diagnose that? Do you do some kind of
No, if dyspnea is the predominant thing and his trachea and other bronchi are not compressed and you are not able to find any other cause for the dyspnea, maybe you can do a contrast CT. I think you will definitely see the cardiac CT where you can see the great vessels, including the pulmonary veins also.
Okay.
Echo can help.
Okay.
Yeah.
Okay, and just in the continuum of this, so who should be diagnosing the post-pneumonectomy syndromes? Should the chest medicine people, or we leave it to the surgeons, those who have operated?
Generally, whoever sees the patient first, and they should have a high index of suspicion if the patient is developing this kind of symptom, you should keep it in the back of the mind. And if you are not able to find any cause where you can pin the dyspnea on, I think post-pneumonectomy syndrome should come to our mind.
Has it been repositioned, or any of us had?
I don't have any experience in repositioning the mediastinum, sir.
Just last question by Dr. Rajat.
Yeah, I had a very peculiar complication in one of my patients. I would like to discuss and would like to have some comments. So there was a right destroyed lung, a lady, 35-year-old. So I did a right pneumonectomy. The patient was all fine after pneumonectomy. About 8 to 9 months later, she presented with hoarseness of voice. And on bronchoscopy, there was paralysis of the right vocal cord. So I went in the literature, and there were complications of left recurrent laryngeal being damaged when we do a extra pleural, mobilization when the lung is very damaged. When I was working with sir, we had one patient in which we had this complication. It improved over time. But literature, I could not find any incidence in which after a right pneumonectomy, there was a right vocal cord paralysis. So if anyone can suggest what could have been the probable cause for this. Only cause I can think of is that there was overinflation of the left lung which pushed the trachea massively to the right side, and the recurrent laryngeal got some severed or praxia or something like that.
There have been variants of recurrent laryngeal nerve where generally right recurrent doesn't come into the thorax.
It does not come into the
chest. There have been
yeah.
variants which are reported where even on the right side, the recurrent laryngeal nerve comes into the thorax and hooks around.
The patient was all right about 8 to 9 months after surgery. Okay. Whatever the recurrent laryngeal injury is, it is during surgery. Yeah. So the patient should present immediately after surgery. Sir, Dr. Diwan. Sir.
I can't fathom out any reason why it happened. Maybe some other condition developed. I
think so. I discussed this with you, sir, when this happened.
I could not fathom it because I have not seen right side.
But 9 months later, why do you feel it should be attributed to only the surgery?
No, we ruled out all other causes. There was no other cause which was discernible.
So why would you do a pneumonectomy in that case?
I think we are.
Thank you.
Thank you.
So thank you, Dr.
Next, so I would now invite the next speaker, Dr. Saransh Bansal. He's a young and dynamic thoracic surgeon and specialist grade 2 in the Department of Thoracic Surgery at NIT RD, and he will be speaking on the topic of approach to a patient with pneumomediastinum. Dr. Saransh.
Thank you. Sorry to have come a bit out of turn because in the interest of time, yesterday I could not do my talk. I'm Saransh Bansal, a thoracic surgeon at NITRD, and my talk today is about the approach to a patient with pneumomediastinum. Pneumomediastinum, plainly speaking, is presence of air in the mediastinum, and it's classified into two: a spontaneous pneumomediastinum, which we encounter both in our clinical practice, which has predisposing factors like tobacco use or drug usage, and a secondary pneumomediastinum, which could be iatrogenic through procedures like endoscopic procedures, post-intubation, pleural cavity instrumentations, central venous access. And the second in the secondary pneumomediastinum is traumatic. It could be post-blunt injuries or penetrating chest traumas. It could be non-traumatic, secondary to inherent pulmonary diseases such as asthma, COPD, bronchiectasis, ILDs. Usually the presentation is in young, tall, lean men, and chest pain is the most common presenting symptom. Usually it's retrosternal with radiation into the neck or the back. This is true in about 60% of the cases in most reports, and even up to 100% of cases. It's sudden and very acute in onset. The other symptoms are dyspnea, coughing spells, neck pain, and in a spontaneous pneumomediastinum, there's usually not much complaint. Rhinolalia, which is a nasal sounding voice because air tracking up towards the neck, is an unusual and a very rare finding, but it could also be found. There is hoarseness and neck swelling also in some cases. On clinical examination, subacute emphysema is one of the most common finding that we find in 70% of the patients, followed by tachycardia, tachypnea, anxiety. There's a classical Hammond sign, which is quite specific but infrequent, which is the presence of a mediastinal crunch or a click on auscultation over the cardiac apex and the left sternal border. It's synchronous with the heartbeat. There's a condition called malignant pneumomediastinum, which is accumulation of a significant amount of air in the mediastinum, causing a vessel or a tracheal obstruction. It could also lead to tamponade or a decreased venous return, which could be catastrophic for the patient. If you look into the literature, chest pain has been reported to be the most common finding or most common symptom in people who have developed pneumomediastinum, followed by dyspnea or neck pain, cough, or even dysphagia. There are the clinical findings that are noted in our clinics are subcutaneous emphysema being the most common, followed by neck swelling or a Hammond's crunch. Some patients can also have an associated pneumothorax, but then the entire presentation is a bit more complex and complicated. The triggering events that were noted was, interestingly, the most common was either the patient had asthma or had a prolonged tobacco or smoking usage or an interstitial lung disease. Also, a lot of patients come in with a history of violent vomiting or violent emesis leading to a pneumomediastinum. So these are all the things we need to keep in mind when we see a patient who's come in with pneumomediastinum, because that is where the cause is. So how do we approach a patient with pneumomediastinum? Well, we have a suspicion of pneumomediastinum with the mentioned clinical findings. We do a diagnostic chest film. If there's nothing that you could find on a diagnostic chest film, we go ahead with the CT scan. Now, if there are findings on the diagnostic chest film, we need to look for the causative factor. Whether it is a suspected or known causative factor, we need to address the treatment. Or if there is no suspected or no known causative factor, we need to observe and see how the patient progresses. It cannot be, a CT scan in a pneumomediastinum is vital to confirm the diagnosis in suspicious cases or in patients who have an inconclusive chest X-ray. It identifies all secondary causes, whether it be in the GI tract, whether it be in the thorax, whether it be anywhere in the mediastinum. It also helps us to differentiate between a pneumomediastinum and a pneumopericardium. The classical signs are a Spinnaker sign, which is elevation of the thymus due to the air. There's another sign called the ring sign, which is air surrounding the pulmonary artery or either of its branches. Then there's a double bronchial wall sign or a continuous diaphragm sign, and air is seen adjacent to the hemidiaphragm or spine. I'm going to go through some pictures of these signs. This is a classical Spinnaker sign. If you see on the CT, there is a lot of air just under the thymus. It is quite classical of pneumomediastinum. This is the ring around the artery sign. You see there's a branch of pulmonary artery and there's air around it. So this is again very typical of pneumomediastinum. This is a continuous diaphragm sign where it looks like the diaphragm is just one layer and without any breaks in the middle. The other investigations, which are usually, well, not usually, almost all the time required to confirm the diagnosis of the cause of pneumomediastinum, a bronchoscopy is a must, an esophagoscopy is a must. Although in a spontaneous, these usually come out to be negative, but it cannot be stressed anymore that how important these investigations are. Laboratory findings are usually inconclusive. They're associated with any inflammatory process. And there are rare findings where there is free air in the spinal canal or the air dissects upwards into the retropharyngeal or the retroperitoneal space. Extremely, extremely rare. So how do we manage pneumomediastinum? Well, it is definitely a benign entity, but it can have catastrophic events. So it's a benign entity of little clinical importance, but with amazing and very good prognosis. The aim is control of pain, stability of the pneumomediastinum, and elimination of complications such as pneumothorax. But first, always, 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 we need to exclude a significant pathology that has led to a pneumomediastinum. So the further treatment is symptom relief. Initially, there has to be a 24-hour observation period with absolute bed rest. We need to control the pain, we need to control the cough, and we need to control the anxiety. Anxiety is something, anxiety from the patient's attendants, from the relatives, from your nursing staff who are not used to seeing someone's neck bloating up. We need to elevate the anxiety as soon as possible. Oxygen support, it increases the gas absorption by 6-fold. So this increases the diffusion pressure of nitrogen in the interstitium and promotes rapid absorption of free air. Next is underlying exacerbation of asthma or COPD, which we've just read through literature, is quite common, needs to be addressed. Extensive subcutaneous emphysema or a pneumothorax. Also, if there is a pneumothorax, an intercostal drain has to be placed. But a lot of times, when there is too much of subcutaneous emphysema and we can't find a clear window, a lung window, we may go for a blind ICD insertion by the open method just to see if there's any pneumothorax there or not. What are the outcomes of pneumomediastinum? Well, spontaneous pneumomediastinum usually resolves by itself. You just need to have a supportive approach and they'll resolve. But prolonged cases have also been reported where the pneumomediastinum has continued for over 2 months. Usually there are no recurrences and there is no long-term follow-up advised as such in guidelines. But at the end of the day, we need to figure out why this happened. We need to do a full checkup, a full imaging pattern of the chest, of the GI tract to see where this happened. So one little note on complicated pneumomediastinum, where there is significant amount of air in the mediastinum, and it's usually associated with a missed esophageal or a airway injury. This is where the term malignant pneumomediastinum comes through. It's basically tamponade, which causes airway and vascular compression, and usually causes these compression, and usually requires some sort of a surgical management. Whether you do it by VATS, a thoracotomy, or a subxiphoid approach with surgical decompression, but it becomes an emergency that needs to be tackled as soon as possible. Thank you.
And majority of those cases we managed conservatively. Many of them died also. But they were with Dr. Rajat, we remembered, we put in through a video thoracoscopic assistance, a catheter in the pneumomediastinal space, and that case resolved. So it's not that we don't have to intervene in any time, but the COVID was a very difficult situation. I've also seen cases of pneumonia, but nothing could be done. I had frantic calls of celebrities that they were admitted there at their pneumomediastinum. Please shift them to this hospital if you can do anything. Generally, we only manage them conservatively.
Yes, definitely so.
Well, on one point, I just beg to differ. You said in case if it is a massive subcutaneous emphysema, and you are not able to see whether it is pneumothorax or not. So you put in a ICD.
Yes.
I think better is get a CT scan done. That will solve the issue.
Sir,
If there is no pneumothorax, I don't think there is any need for ICD.
Sir, actually, that's a very good point and well taken. The problem is we've usually seen patients which are in an ICU setting who are almost about to be ventilated with a severe subcutaneous emphysema. All we can have at that point is a bedside chest X-ray, which just shows air in the subcutaneous plane. So in those circumstances, to shift the patient into a CT scan machine it's very troublesome, and it's actually not even indicated. So it's better to give a local anesthesia. The patient is really dyspneic and anxious. You put in 2 ICDs with the open method. You put in your finger, make a little space, and put in an ICD, no harm done. You can get a chest X-ray when everything is resolved. If out of even 100 patients, there are 10 patients who've had the pneumothorax bilaterally, that ICD is going to really improve the subcutaneous emphysema and really work. In the rest 90 of patients, it was an emergency management that you had to do because we could not shift the patient to CT. So yeah, given the benefit of doubt, basically.
Yeah, but sometimes, in case if because of previous infection or something, the lung is adherent to the chest wall, then you have it.
I've had it once.
Yeah.
I've had it once.
Thank you.
So you will be doing a bilateral ICD insertion?
Yes.
Any other questions? Okay, we can move on to the next speaker.
Thank you.
That's Dr. Prakash Sharma. She is a consultant anesthesiologist at NITRD, and she'll be talking about anesthesia consideration in thoracic surgery.
Good afternoon, everyone. I would be speaking on anesthesia considerations for thoracic surgery. The spectrum of thoracic surgery is varied. It varies from inflammatory diseases of the lungs to the surgeries for lung cancer, resection of bulla, and surgeries for lung transplantation. This spectrum is also varied in terms of risk for the patient. That is, these diseases varies from low risk surgeries to high risk surgeries. And this spectrum currently is also changing in terms of surgical approach. That is from open thoracotomies to minimally invasive thoracic surgeries. And as this spectrum changes, the anesthesia considerations for thoracic surgeries also keep evolving. To start with, we have the preoperative evaluation. Starting with the classical evaluation, which is done by the anesthesiologist per se. And in the previous lectures covered, Dr. Kapoor has highlighted all the details which the anesthesiologists are supposed to look into. The most important of them are the difficult airway. Next is a risk factor analysis, which is the pulmonary risk, the cardiac risk, the assessment of the frailty, and the pain management. The pulmonary risk has also been covered in the previous lecture. Starting with the cardiac risk, which is thoracic revised cardiac risk index given by Brunelli et al. In 2015, where 4 risk factors are considered very important, and where pneumonectomy is given equal points compared to cerebrovascular disease and cardiac ischemia. Serum creatinine also has a very important role to play. So depending upon the risk class that the patient is allotted to, the risk of cardiac complications the risk of cardiac complications varies with the risk class, and it is maximum to the point of 23% in a patient who has a thoracic cardiac risk index of more than 2.5. In a very few patients, we have assessment for right heart failure and pulmonary hypertension, which is looked on an echocardiography, where one looks for right ventricular free wall motion and right ventricular fractional area change. Now, what earlier we used to assess as the general condition of the patient is now being assessed as a frailty assessment, where we assess for weight loss, weakness, exhaustion in a patient, slowness and low activity and cognitive impairment. The evaluation for pain management is of utmost importance for the anesthesiologist and also for thoracic surgeries, where we specifically assess for pain, the risk factors which are specific for the patient, and the pain because of the surgery per se. Starting with the general considerations, the most important considerations for an anesthesiologist's point of view are the devices for lung isolation, the choice that we have to make, the physiological changes which occur because of lateral decubitus position and an open chest, the desaturation during one lung ventilation, the prevention of acute lung injury, the intraoperative fluid therapy, and the modulation of hypoxic pulmonary vasoconstriction by the current anesthetic agents that we use. The lung isolation devices which are available to us are the Wmin tubes and the bronchial blockers, out of which a Wmin tube is preferred because of ease of placement, the ability to ventilate both the lungs, one or both the lungs, and ability to suction either of the lung. The Wmin tube comes with its own issues in terms of proper size selection, the placement of a Wmin tube, the positioning, especially for a right-sided Wmin tube, where the opening of the right upper lobe bronchus has to be aligned with the opening which is present in a right-sided Wmin tube, confirming the placement, the safety, and the complications. Now this is a Wmin tube which is available in two sides, the right side and the left side. These are the bronchial blockers. There are very specific indications for a right-sided Wmin tubes, that is, if a patient has a distorted anatomy of the left main bronchus by intra or extra bronchial mass, the compression of the left main bronchus due to descending thoracic aortic aneurysm, a left-sided pneumonectomy, a left-sided single lung transplantation, and a left-sided sleeve resection. Despite the concerns about right upper lobe atelectasis and potential difficult placement of a right-sided Wmin tube in terms of alignment of a right upper lobe bronchus with the opening, we have failed to detect any differences in clinical performance of a right over a left Wmin tube at our institute. The bronchial blockers, they may appear to be very, very lucrative, but they come with own sets of indications and limitations. The indication for putting in a bronchial blocker would be one, a difficult airway, where putting in a Wmin tube would be difficult because of the extensive diameter of a Wmin tube. In a child of less than 10 years of age, because the smallest Wmin tube can be put in a child of 8 years of age, whenever we need a selective lobar blockade, or a patient who has suboptimal pulmonary function test, and a patients who require a post-operative mechanical ventilation, where we put in a single lumen tube followed by a bronchial blocker, where after end of the surgery the bronchial blocker can be removed and patient can be shifted to the ICU with a single lumen tube itself. The limitations are malposition, inadequate suctioning, because the channel available for suctioning is very less compared to a Wmin tube, and of course a slow lung collapse. Fiber optic bronchoscopy is a must. It is the gold standard when we have to provide one lung ventilation. It is the most important armamentarium for an anesthesiologist. It is various sizes are required for successive conduct of thoracic surgery. For a tube of 26 to 28 French gauge Wmin tube, a scope of 2.2 to 2.8 millimeter outer diameter would be enough, and for the rest a 3.5 to 4.2 millimeters. This is a table which gives the correlation between the Wmin tube French size, the outer diameter of the Wmin tube, the bronchial diameter and the tracheal diameter. This table shows us that these are the size of the Wmin tubes and these are the size of the various bronchoscopes which are must for the anesthesiologist to give one lung ventilation. Now, after putting in a Wmin tube, the confirmation of a placement of a Wmin tube is of utmost importance. This is a bronchoscopy which has been done through a left-sided Wmin tube. Now, this is the Wmin tube, the carina, and this is the Wmin tube has got two cuffs, the bronchial cuff and the tracheal cuff. The bronchial cuff is the one which is passed beyond the bronchus. So, the bronchial cuff should be just beyond the carina. It should be just 2 to 3 millimeters beyond the carina, and it should be visible when we do a bronchoscopy. So, in this case a Wmin tube has been slightly more inside the carina because we cannot see the bronchial cuff here. This is a right-sided Wmin tube, and again the blue cuff should be just beyond the carina and it should be just visible when we do a bronchoscopy. And of course alignment of a right opening which is present in a right-sided Wmin tube with the right upper lobe bronchus is of utmost importance. Now this is when we do a bronchoscopy for placement of bronchial blockers. This is the carina where this is the bronchial blocker which has been placed in the right main bronchus. Again, this is an EZ blocker where this is a blocker where we have two bronchial blockers and the bronchial blocker is placed as the cuff. Again, depending on if a bilateral thoracotomy is to be done, then the respective site can be inflated of the bronchial blocker. Now the positioning during anesthesia for thoracic surgery is of utmost importance. That is when we place a position in a lateral decubitus position and we anesthetize the patient. So once we anesthetize the patient, we realize that the upper lung, which is being ventilated more, it is being ventilated more, it is more compliant, whereas the dependent lung receives greater perfusion, leading to a ventilation perfusion mismatch. That is the cause of the hypoxia which we deal with one lung ventilation. Again, once the patient is in the lateral decubitus position, there is an open pneumothorax. So during inspiration, there is an increase in the pneumothorax and the gas flows. It flows from the upper lung, that is the lung which is being operated, to the lower lung across the carina. And during expiration, there is a decrease in the pneumothorax. Now once the patient, now again this patient is in the lateral decubitus position and open pneumothorax. During the inspiration, there is a shift of the mediastinum towards the downward sides. So this is the lung which is being ventilated. With the mediastinal shift, it will lead to the compromise on the tidal volume. Other than the problems that we face, the most important thing is the intensive intraoperative monitoring. Other than the routine monitoring, that is the monitoring of the 12-lead ECG, the blood pressure, non-invasive blood pressure, temperature monitoring, ABG, we have an intensive intraoperative monitoring in terms of invasive blood pressure or continuous central venous monitoring. And of course, pulmonary artery pressures, we do not have any indications for carrying out a pulmonary artery pressure monitoring at our setup. Now, initially with one lung ventilation, there was issue of hypoxemia, which we were all dealing with. But with better lung isolation methods, the ventilation techniques, the use of anesthetic agents with less of detrimental effects on hypoxic pulmonary vasoconstriction, the current attention has shifted to the avoidance of acute lung injury in the lung which is being operated upon and in the lung which is being ventilated. So this is what we have called as a protective lung ventilation strategy. This decreases the pulmonary, so there is a increase in the production of pro-inflammatory cytokines during one lung ventilation, and this is not only in the lung which is being operated upon, it is more in the lung which is being ventilated upon also. So the strategy is the use of tidal volume of 6 to 8 ml per kg, a use of PEEP 5 to 10 centimeters of water, the use of lower FiO2 50 to 80% of FiO2, a plateau pressure of less than 25 centimeters of water, and a permissive hypercapnia during the operation. There is an approach that has to be followed to minimize the acute lung injury during thoracic surgeries, and there are various mechanisms, and with the mechanisms come the suggestive measures. So surgical trauma is one of them. We should consider a minimally invasive thoracoscopic surgery, which can either be a video assisted thoracoscopic surgery or a robotic surgery. The ischemia reperfusion or the oxidative stress can be managed by decreasing the one lung ventilation time as much as possible, using the lowest FiO2 possible. Also, when we re-expand the operated lung, one has to take care that it has to be re-expanded with the ventilator instead of a bag, the manual ventilation in a stepwise and a slow recruitment manner. The local hypoxia caused by atelectasis is again decreased by decreasing the one lung ventilation time and the various recruitment maneuvers. In terms of positive fluid balance, the damage which is caused by a positive fluid balance for a patient undergoing thoracic surgery, a goal-directed fluid therapy is must so as to keep a normal cardiac output and oxygen delivery at the lowest amount of IV fluids that we have to give to the patient. Low doses of vasoactive drugs are of utmost importance. Inhaled beta-2 agents to decrease the pulmonary edema, and hydrocortisone to preserve the endothelial glycocalyx. The capillary stress failure again can be decreased by slow vascular clamping and declamping of the arteries and avoidance of high doses of inotropic and vasoactive agents. The incidence of ventilator-associated lung injury has already been discussed earlier. Now the recruitment maneuvers and the open lung concept has two main components, that is active opening up of the collapsed lung units by a recruitment maneuver and use of high levels of PEEP to keep the lung units open. The rationale of this is to decrease the FRC in order to normalize the lung functions and to avoid the mechanism which are causing ventilator associated lung injuries. Now the need for recruitment, despite using the protective ventilation strategy, it has been seen that this strategy does not totally abolish the ventilator associated injury during one lung ventilation. In fact, the use of protective ventilation strategy, it promotes lung collapse, and therefore this lung de-recruitment, it has to be avoided by application of PEEP and frequent recruitment maneuvers. A recruitment pressure of not more than 40 centimeters of water with a PEEP of 20 centimeters water is appropriate, and it is advisable to use a slow stepwise recruitment maneuver which causes less stress to the lung tissue than a fast recruitment maneuver. The advantages of these recruitment maneuvers is that not only it eliminates the total venous admixture that comes from the ventilated lung, it also restores the FRC, improves the gas exchange, and also avoids the need to provide a complementary CPAP in the operated lung, which we have to do at times. Timing of the recruitment maneuver is very important. That is, one is immediately after anesthesia induction, before the starting of the one lung ventilation, so as to benefit from the positive effects of the recruitment maneuvers which are during the entire anesthesia time, and the second recruitment maneuver should be performed once the operated lung is being re-expanded. The fluid management in thoracic surgeries is very, very important. The fluid it has been seen that the fluid which is being administered has a direct correlation with the post-operative pulmonary complications. So what we follow is a goal-directed therapy in thoracic anesthesia, which is beneficial especially in more risky patients, so that we can achieve optimal oxygen supply and consumption balance. It avoids hyper and both hypovolemia, that is lung edema and kidney injuries are avoided by it. However, the evidence is low and it has its own limitations. The reputation of a restricted fluid management in thoracic anesthesia, it is far more exaggerated than its evidence, and a goal-directed therapy in any case is more objective approach, and this must be followed in patients who are very severely ill. So for fluid therapy, the strategy would be maintaining normovolemia intraoperatively, fluid of less than 6 ml per kg per hour. One should decide for making for fluid optimization rather than fluid responsiveness. The correct timing of fluid administration is also very important. That is, only when patient is hypovolemic, the fluid should be administered and not in a normovolemic patients. And in thoracic anesthesia, the hypotension caused by acute hypovolemia is not impossible to recognize, and also decreased inotropy is very, very rare. So usually it is a vasodilatation leading to hypotension, and thus the use of vasopressors would be more appropriate than the use of more fluids or inotropes for these patients. The other strategies that we affect, which I think would be covered in the next lectures, that is enhanced recovery after thoracic surgeries, that is to minimize the preoperative fasting time as much as we can, the protective ventilation, the minimally invasive thoracic surgery, early post-operative feeding, and post-operative analgesia. So this is just one last slide. This is endothelial glycocalyx. It is a gel-like layer lining the luminal surface of healthy vascular endothelium. And it has been seen that if there are attempts to minimize the degradation of endothelial glycocalyx by various techniques used by anesthesiologists, that is avoidance of hypervolemia, reducing the stress response, and decreasing the systemic inflammation, this has a positive effect on the recovery of the patients. Of course, pain management is of crucial importance not only for patients but for the recovery of the patient also. The thoracotomy is associated with very severe pain leading to most of the respiratory complications, and also the inadequate management may also lead to post-operative post-thoracotomy pain syndrome, which may last for months and years in patients. In our setup, we use a multimodal analgesia for pain management in terms of not only parenteral opioids and NSAIDs, but various blocks as thoracic epidural blocks, paravertebral blocks, intercostal nerve blocks are used by surgeons itself, erector spinae block and serrator anterior block whenever they are indicated. Thank you. Any questions?
I do not think anybody has any question after such a lucid talk given by Dr. Prakash. And considering the time limits, I think we move on to the next speaker. The next speaker would be Dr. Sahiwal Khandelwal. He's a senior consultant and HOD of minimal invasive thoracic surgery at Max Hospitals, New Delhi. And he would be talking about ERAS in thoracic surgery. Dr. Sahiwal. This is the last session of the today's, or I would say the last session of the CME being conducted. This is the last. There's nothing up this.
Good evening, everyone. Thank you, Dr. Diwan, Dr. Pallavi, Dr. Saransh, for inviting me here. I'll try to finish it in time. We'll go fast. Enhanced recovery after surgery. The ERAS Society was established in 2001 as the continuation of fast-track surgery, which was first used for colorectal and gynecological surgeries. The aim was the quality of the recovery, not the speed of surgery. The components was multidisciplinary team, multimodal approach to resolve issues that delay recovery and cause complication, scientific evidence-based protocols, changes in patient management using interactive and continuous audit, and the entire patient journey from time of surgical referral until post-operative discharge from the hospital. The ERAS Society has given plenty of guidelines for almost all the surgical specialties. In thoracic surgery, they have given guidelines for lung surgery and esophagectomy. This is basically the most extensive and most exhaustive paper which has given guidelines for ERAS, has been given by ERAS Society and by European Society of Thoracic Surgeons. I have taken most of the slides from the primary author, which is Tim Batchelor. So basically, after any surgical impact, there is a decrease in the level of functioning. There is an early deterioration in the functioning of the patient, followed by the recovery. As the time progresses, the patient reaches the minimum level of function and he is subsequently discharged. But the deterioration is more if the patient has pre-existing COPD, the level of fitness is less, the extent of surgical resection done, and if the patient has extremes of BMI, either extremely low or extremely high BMI. And similarly, the recovery is also influenced by existing factors like pain, nausea, nutrition, smoking status, patient is not mobilized after surgery, presence of dupes like chest drains, urinary catheters, central lines, and the fluid status of the patient. So the difference from the base and up to a minimal level of recovery, if it is not obtained, and this is called as inadequate functional recovery, which will lead to the complication, longer hospital stay, subsequently the increased cost to the patient. And this is the place where the ERAS comes in. It defines it intervenes in all the phases from pre-operative phase, admission, operative phase to post-operative phase. The goal of ERAS is on the emphasis of the quality of the recovery to promote the homeostasis after the insult of surgery, so that the stress of the surgery is reduced to achieve less complication, quicker return to the normal functions. The reduced cost and the shorter stay in the hospital is the byproduct of the intervention. This is not the aim of the ERAS. After any surgery, you can see there is an stimulation of the brain by sympathetic system, by hormones, which in turn secretes plenty of cytokines, which promotes protein catabolism, hyperglycemia and insulin resistance. There is a catabolic state, loss of protein, cellular dysfunction, insulin resistance impairs cellular function during injury to the tissue, and all these things we don't want after any surgical trauma. So this is the place where ERAS comes in. After any surgical trauma, we can see the whole idea of ERAS is to minimize the impact of the surgical trauma and to accelerate the healing after the surgery. The key question was, what is the optimal perioperative management for patients undergoing lung surgery? And under 21 sections, 45 ERAS elements were described, which can be modified along with the use of systematic multimodal perioperative care pathway that has the potential to improve the outcomes after lung surgery. These are the various ERAS elements in various headings. So I will quickly go through what all are important, like pre-admission counseling information. It's very important. It's not harmful, but definitely improves in the patient's pain after the surgery. Perioperative nutrition, the patient should be screened preoperatively for nutritional status and weight loss. If required, then they can be given nutritional support. See, smoking and alcohol are associated with increased risk in post-operative morbidity and mortality, and ideally should be stopped at least 4 weeks before surgery. Anemia should be detected, adequately worked up and treated. If not, then there is a higher incidence of complication in the post-op. Pre-rehabilitation of the patient with borderline lung function, not exercise capacities, strongly recommended by the ERAS Society. Patients should be permitted to drink clear liquids up to 2 hours and solids up to 6 hours before surgery or anesthesia. Oral carbohydrate loading reduces post-operative insulin resistance, improves preoperative well-being, and should be used routinely. This strategy has been taken from colorectal surgery, and there is no evidence for thoracic surgery. Almost it is being utilized now. The use of sedative drugs before surgery should be avoided. Mechanical and pharmacological prophylaxis for VTE should be done. Routine antibiotic prophylaxis should be given within 60 minutes. Hair clipping is recommended. Chlorhexidine alcohol solution is preferred to the povidone iodine solution. Monitoring of patient's temperature is mandatory to guide therapy and to avoid hypothermia and hyperthermia. Maintenance of normothermia with convective active warming devices should be used perioperatively. Anesthesia protocols has been discussed by the previous speaker. We should aim for early extubation. Lung protective ventilation strategy should be employed. Non-intubated anesthesia is currently not recommended, and both short-acting like inhalational, interventional or intravenous anesthetic can be used. The management of post-operative nausea and vomiting is very important. Use of both non-pharmacological measures and a multimodal pharmacological approach for the nausea and vomiting prophylaxis should be done. A standardized multimodal approach to the pain relief, including good regional anesthesia. Paravertebral blockade provides equivalent analgesia than thoracic epidural and should be preferred. Acetaminophen and NSAID should be administered regularly to all the patients. Dexamethasone may be administered to prevent post-operative nausea and vomiting and reduce pain. Ketamine should be considered for patients with pre-existing chronic pain and long-term opiates. Very restrictive or liberal fluid regime should be avoided in favor of euvolemia. Intraoperative hypoperfusion can be avoided with the use of vasopressors and a limited amount of fluid. Balanced crystalloids are the intravenous fluid of choice and should be discontinued as early as possible, and early enteral nutrition should be started. Avoid withdrawal of beta blocker as they will lead to the atrial fibrillation as a post-op. Magnesium supplementation may be considered in magnesium depleted patient. There is a low evidence for the prophylactic use of diltiazem of amiodarone or amiodarone prophylaxis for these patients. Muscle sparing thoracotomy incision may reduce post-operative pain and preserve muscle function and should be performed wherever possible. Intercostal muscle flap and nerve sparing techniques are recommended as they reduce post-operative post-thoracotomy pain. Avoid compression of the inferior intercostal nerve whenever the ribs are reapproximated. A VETS approach of pulmonary resection is recommended for early stage lung cancer. The benefits are even more marked in patients with poor respiratory reserve. The number of ports used does not appear to affect VETS outcome, and so one VETS approach cannot be recommended over the another. Data to support the routine use of robotic surgery are lacking until these guidelines were framed. Chest tubes are painful and inhibit respiratory function. The routine application of external suction offers no advantage and should be avoided. The use of digital drainage system is recommended. Chest tubes can be removed safely even if the daily serous effusion is high, up to 450 ml. Single tube should be used instead of two after a routine anatomical lung resection. The transurethral catheter is not required if its sole purpose is the monitoring of the peri-operative urine output. Post-operative urinary retention is associated with thoracic epidural, and it is reasonable to insert a catheter in these patients. The recommendation on the timing of removal cannot be made. Patients should be mobilized within 24 hours of surgery. Prophylactic mini tracheostomy use may be considered in certain high-risk patients. The routine use of post-operative non-invasive positive pressure ventilation cannot be recommended. So there were criticism for all these surgeries as these guidelines were serialized because there were too many recommendations to follow. Almost 45, around 40 have a strong recommendation. Some evidence is just transferred from other specialties like colorectal and gynecological. Some items are already standard of care in most of the units. So now a brief about the data, about the, after implementing these ERAS guidelines, what was the impact? So this study was from US, which compared their outcomes after thoracotomy in pre-ERAS and post-ERAS era. They have seen a decreased overall length of stay, reduced pulmonary and cardiac complications. This is a detailed systematic review and meta-analysis done in 2021. And they also reported a reduced length of postoperative stay, less postoperative complications, decreased readmission rates. Another systematic review and meta-analysis also suggested decreased postoperative complication. The readmission rates are almost similar. The length of stay post-op is less. Now talking about the compliance. As the number of compliance with the number of ERAS protocol elements increases, the percentage of morbidity reduces. Similarly, the percentage of delayed discharge also reduces as the compliance with the number of ERAS elements increases. This was also found in another study, similar results. So are all the components equally important? No. So some elements are more important, like carbohydrate loading, early mobilization, early removal of chest tubes, early cessation of opioids, and VATS is now a standard of care after lung resection. So carbohydrate intake loading is taken from colorectal and gynecological surgeries. We have already talked about that. So early mobilization is the intuitive component of ERAS. If you don't do that, there are higher post-operative pulmonary complications, higher incidence of venous thromboembolism. There is a physical deconditioning and loss of muscle mass if the patient is not ambulated early. So this study suggested that there is a better FEV1 and better SpO2 once the patient is in standing position. Early drain removal reduces drain pain and improves respiratory function, has been very well documented in a variety of studies. So this study studied both in robotic and VATS and in thoracotomy. With the implementation of VATS, there is a significant improvement in the pain scores, significant less utilized of the opioid medication after discharge in both the groups, in VATS as well as thoracotomy. So talking about the summary, ERATS improves surgical outcomes and is associated with a reduced postoperative length of stay. Increasing compliance with ERATS pathways associated with better patient outcomes. Some ERATS elements appear to be more important than others, including the use of VATS. So enhanced recovery after lung resection is knowing what we can do and doing it. Thank you.
Thank you, Dr. Saiwal. Any questions, anybody? This lecture has been an eye-opener because you see, whenever we have met the surgical or the anesthetist team, they always tell us nothing to be eaten. Empty stomach, we thought was always 6 hours of no liquid, nothing. But he has told that as per it has to be 2 hours before you can take liquids. So I hope that is going to be the protocol for us also now.
I just want to know one question.
Reasons not to follow many things.
Yeah.
Practical and logistic reasons.
Yes, sir.
For instance, in an institution setting, if you say 2 hours, if you say the night before surgery, it's more practical. That's all. Most of the things stand to logic, but to be implementing them requires much more sustained effort from various aspects of the team members. That is the reason. Otherwise, it's not that they are illogical, and we and Prakash Sharma, everybody, all of us are working towards utilizing as much as possible of these elements.
So the final verdict is that we keep the patient fasting still.
Huh?
Overnight.
No. The verdict is not that.
No.
6 hours or 2 hours, if it is
6 is
feasible, is fine. Absolutely.
I've been using 4 hours of fasting post, yeah. So, and since last 1 year, I've been using ERAS protocol and been doing non-intubated lobectomies. So I've been admitting on the day of surgery, operating and discharging the next day with or without ICD. Not putting in the whatever ICU. Carefully selecting this case. Lot of cases I have done under intercostal nerve blocks and speaking with the patient and doing bullectomies. Yeah, that is also possible, but definitely it requires a lot of expertise, one-to-one communication with the anesthetist team. Very much, if any time patient presents pain, I tell anesthetic start propofol, and he has to be quick in intubating the patient in lateral position.
I want to know one thing. You have mentioned that chest tube drainage with 400 ml per hour, per day. Are you really discharging the patient with 400 drainage chest tube? You cannot.
Sir, the studies have documented.
You have recorded, but nobody is discharging the patient with 400 chest. Drainage. You are not going to remove the chest tube. At least if it's less than 100 or 150 is acceptable. But I don't think anybody is doing that.
He told me that even with 400, if it is clear fluid, he was actually removing the chest tube and getting away with it. It's only his experience. You see, for ours, this is number one, there has to be no air leak. If air leak is present, I cannot remove a chest tube. And if the drainage is bloody, it has got some purulent element, it is not absolutely clear, out of question, even if it is 5 or 10 cc. About serious clear fluid coming, there is a debate. I will wait for it to become less than 50 cc still.
So now the current...
Another thing I want to know that all these meta-analyses, the studies included were all VATS, or they were comparing thoracotomy also along with that, because the VATS and thoracotomy will just, those advantages may be of the VATS rather than of the ERAS.
Yes, sir. VATS is an independent factor, and they have also recommended minimally invasive techniques. And most of the studies I have shown there have compared uses of ERAS elements and without use of ERAS elements.
In the VATS alone?
Sorry, sir?
Only in the VATS cases?
Both.
If you are comparing VATS with thoracotomy, the VATS is an independent
factor. There is no comparison of
all the benefits of the VATS. They are, decreased length of stay, decreased pain, decreased chest tube, and early discharge. All these are, in spite, if you don't put any of those ERAS protocols, just use the VATS, probably all these things will be done.
There is an aggregation of all these elements actually, which influences the better outcome. VATS is an independent factor.
VATS is an independent thing, and you cannot actually force it that you will have only VATS, then you cannot do that. Many cases cannot be done
and
through VATS.
Even in open
and many surgeons will not do through VATS also.
Yes,
so
sir.
that is
I will add on to this. This all data is Western data. And in India, we have a lot of patients which will have other associated diseases, as adhesions will be there. And if you see, I have seen in my experience, if they are clean-cut lobectomies without mediastinal nodal dissection, something like VATS, wedge resection for metastasectomy, yeah, definitely the drain output is less. You can remove the drain on the next day and discharge the patient. But if you are operating for some bronchiectasis and you want to do ERAS protocol, definitely the drain output has been not more than 200 ml, 200 to 400 ml. And for lung cancer cases, definitely the output has to be high, because you do a lot of lymph nodal dissection and lymphatics will be opening up. It will take at least 2 to 3 days for the drain to settle. Maybe after 3 days it will become less than 200. That is acceptable situation. I have done this. I have removed the chest tubes at 400 ml, but then the fluids kept on rising, and then I had reinsertion of chest tube. That is much more dangerous, and it will, complications like empyema and all these things are, you are giving a way to this. Yeah, yes, yeah.
Thank you.
That was the last talk of this session, and for that matter for the CME also. I thank the chairpersons for this interactive session. Now may I please call upon stage Dr. Saransh Bansal, the Joint Organizing Secretary of our conference, to come to the dais and deliver vote of thanks and to conclude the evening.
I think, please thank you, chairpersons. I think, why don't you take chair? Let me now, just a very brief, it's not a closing ceremony per se, don't worry, we are not going to hold on people for a long time. I request Dr. C.S. Hiremet, the Secretary of Indian Association of Cardiothoracic Surgery, who has been very patiently, though he is not a very exclusively dedicated thoracic surgeon, he has sat through the 2 days of the conference, and under the auspices of this association, we have been able to do this conference. I want his comments.
Good evening. I think it's a very well organized thoracic CME, and Dr. Ravindra Diwan, Dr. Pallavi Purwar and Saransh and the entire team have put in a lot of efforts. Almost for the, she has been planning since almost from the month of February of this year. And finally, the output is really excellent. In fact, 2 days of scientific feast with almost covering most of the topics in thoracic surgery. Not only this, the quiz which was introduced yesterday was one of its unique of its kind. Normally we have quizzes. In fact, I keep conducting quiz for the last almost 10 years in our association. This quiz was totally different, more of case oriented, a thinking process, and the way the questions were formulated with the visual impact of the X-rays and the CT scans is a big learning by itself for the students. And we had a lot of discussions regarding the DNB training curriculum in this session, as the DNB board was here. In fact, today evening, late evening, another meeting has been fixed with the president also. Many of the thoracic postgraduates have come up with their concerns. Thoracic consultants have come up with their concerns. Definitely I will see that those concerns are addressed. If not today, tomorrow, very shortly we will address these concerns and take it forward and see that thoracic specialty, people who are trained have no dearth of work in our country. There are so many number of cases. Definitely we will work together towards it and see that everybody is happy in their profession. Once again, I would like to thank Dr. Ravindra Diwan and Pallavi for an excellent show of this program for the last 2 days.
Okay. Thank you, Dr. Hiramat, and I'm sure 2 or 3 takeaways can be definitely summarized. Number one, we know that as thoracic surgeons for many years, 5 of us would be giving our talks, another 5 would be listening to it. That number has increased to 70-80 persons who are interested in thoracic surgery and now further taking. And the younger generation actually is exploring new horizons and new areas, and they are the kind of papers they present in which there is detailed research as well as their own insights into all the presentations, which generated interesting discussions, which is definitely not only deep, I won't call it departure, but a much more improvement and refinement than our earlier meets, and it is refining day by day. And in addition, whatever curricular changes which Dr. Hiramat is working with Diploma National Board, etc., we will further refine the curricula of the teaching schedule also, because it is incumbent upon us to develop the curricula which addresses the needs, which are emerging needs, the recent needs, and is addressing the contemporary needs of the society, which may include those needs which are persisting before as well as the newer emerging needs. So that's why it's very relevant. And those concerns, in the able leadership of Dr. Hiramat as Secretary of Indian Association of CT Surgeons, I'm sure we'll be able to meet these challenges. I'm also thankful to the colleagues from other than the Department of Thoracic Surgery in my institute, who have also taken a lot of active part, from anesthesia, from chest medicine, microbiology, pathology. Everybody has taken an active part and have supported in this endeavor of ours. And now we can ask Saransh to deliver his vote of thanks.
Dr. Saransh Bansal.
Thank you very much, sir. Thank you very much, Hiramat, sir, for giving us the opportunity to host this academic feast here at our institute. It was an absolute pleasure. We had great sessions yesterday: lung cancer, diaphragm sessions, and tuberculosis sessions. We all thank you. And as they say that behind any successful event, there is not one person but an entire team. So let me just have my team here. This is Dr. Prerna, who's been emceeing since yesterday. Big round of applause. Can I ask Dr. Rama to come up on stage? He's a specialist thoracic surgeon with us. He's been working behind the scenes. Can I ask Dr. Kanishk? He's also in our department. Dr. Vinay, Dr. Suyog, Dr. Sunita. Please. I can have the entire institute here, but I think everyone has had an equal part. Everyone, Department of Microbiology, Department of Chest Medicine, and last but not the least, Dr. Pallavi, if I may please have you on the stage. and say a couple of words.
It's been a privilege and honor to be back here at NITRD for this event. And not just for this event, I've loved this institute forever, but it has been a privilege of Diwan sir for offering us the opportunity, and we've learned teamwork, and now we work as a well-oiled machine. So thank you, team NITRD. I think we've not thanked Saransh enough for all the behind-the-scenes work that he's been also doing for all of us. Thank you so much, everyone, and thank you so much, Hirimat sir, for the best kind of coordination that we received from IACTS. We are really humbled for the opportunity.
Okay, son. Let's join us for a cup of tea or coffee. What do you want?